you on fibroids, evaluation of fibroids. I do not have any interest to conflicts of interest to declare really, except to just let you know that I'm more into fetal medicine than into gynecology. But the reason why I do for their patients, where they really need to know what is going on. The reason why they ask me to do it is because the majority of people who do gynecology scans, they don't do transvaginal scans, which is really I'm sure my video is refused to turn on, so I guess I'm disabled from sharing the video, but it's okay. So yeah, so that is how I end up doing gynecology scan, but my passion is with looking at the baby. Let me see. Now it's refusing on my side. I think it's to do with my sharing device. So let's see how far. Okay. I think I'm in a position to share my video with my other device. So let's begin the talk on fibroids in pregnancy. So this is the outline of my presentation. So we will just revise because I think we once did an evaluation of endometriosis talk together. So I'll just repeat some of the things that I think they ought to be repeated on basic gynecology ultrasound. Then I will just highlight clinical presentation of fibroids. This is not a new subject to probably the majority of you. Maybe it's just a matter of reminding each other of of certain clinical snippets that we may sometimes overlook, or we may not be aware of how important it is to emphasize certain information whenever you evaluate women with fibroids. Then, of course, I will just go through with you again on recognition and classification of fibroids. Then the fibroids, I'll also discuss fibroids and fertility and fibroids and pregnancy. And of course, I'll mention briefly the differential, and we'll be done. In 30 minutes, I think we should be through this presentation, not very long. So some of you are aware of this slide. I've presented it many times. What I'm trying to emphasize here is that we should aim for the perfect way of doing things, or the best way of doing things. Honestly, none of us in this modern day, in 2022, should be just using transabdominal ultrasound as the only way of evaluating the woman's pelvis in non-vigo intact women. We are aware that Africa is stuck in the 1950s or 1960s, but there's no one who's going to come and move Africa forward for us. Don't expect that someone will come and tell you to stop and to improve yourself. It is actually you who can choose to say, I want to be the change. I want to improve myself. I want to start doing it properly, like it should be done. So no one should be using transabdominal scan in non-vigo intact women, in women who have not refused consent to evaluate a pelvic problem alone. I must say we should use it, but I'm saying we don't use it alone. It should always be combined with transvaginal assessment. This is very important. The same message applies when you are evaluating fibroids. You know, you understand why I'm saying this as we continue the presentation. if you have a machine that can do 3D, again, learn how to do 3D on uteruses, so that you can probably begin to suspect or to diagnose often means disorders such as Mullerian abnormalities, or even location of fibroid, proper localization or proper myoma mapping. You can do that with 3D. There is another modality which I didn't mention on this tab here, which I just want to introduce, called saline sonography, whereby saline is infused into the endometrial cavity to allow for proper visualization of endometrium lesions. It is not very complicated. It is something that we should move towards. We have done it on few cases in our unit for women, where we have been requested to evaluate and see if the woman has got a polyp, whether it's got a fibroid. So we have done it in very few cases, but it's not something which is very complicated. It's not something that is beyond us here in Africa. So it is up to us to improve how we do things. This is why I'm mentioning these things, and I'm saying this should be done in your centers where you are working. And there's no one else to make sure that they're done except you. So don't expect that somebody else is going to come and tell people that we should do saline sonography to try and map endometrial pathology. So yeah, and these are the nomograms of the uterus. We should always be aware of. This is what we call normal. Because for you to be able to recognize abnormality, first of all, you should know what normal is. So this is normal, what we are looking at. So far, so good. So I'll just continue. Then what is the purpose? Why should, when you are scanning a woman who has fibroids or who is suspected of having some pelvic mass, and those pelvic mass are fibroids, why are you doing it? You are doing it because you want to explain the underlying symptoms, because normally these women come with symptoms, as you see in one of my slides. They come to you because they are suffering from pain, or either they are suffering from menorrhagia. So you want to be able to explain to the patient why they are going through what they are going through. All of us, if we are not well, then the thing that we all desire to know is, why am I not well? Why am I having these symptoms? Because that's the beginning of correction or treatment of the problem. So we do it so that we can explain the underlying symptoms. So this therefore means that you cannot examine a patient you don't know the history. So you should ask your patient why they've come to see you for that scan. History is always important. You do not scan a person you don't know. The moment you begin to scan people you don't know, you are more likely to get it wrong. So always take brief history on the patient if you don't have time. But if you have time, take detailed history of the person you want to scan, so that you know why are you scanning. This may even help you in terms of the kind of scan, the kind of issues you want to diagnose. I think I've lost you on my audio device. I just want to ask and say, can you guys hear me loud and clear where you are with the sharing device?
Because I was afraid the sharing device doesn't have a good volume. Can you hear me loud and clear?
Yes, you are.
Yeah, so I'll continue with the sharing device. Probably it's now sorted with the audio issue. The audio device has gone off. Right. So I was saying myoma mapping. I'll explain in detail what myoma mapping is later on. But I'm saying when somebody wants to go for surgery for the ultrasound scanner should make an effort to explain where exactly the fibroid is, because the approach to surgery is different. If somebody is a submucosal fibroid, certainly this submucosal fibroid may be done through a hysteroscopy. But it can be done through instruments that are put inside the endometrial cavity, compared to somebody with a fibroid which is subserosa. If people are going to bridge the endometrium, they need to understand that they have to bridge the endometrium because one of the fibroids is abutting on the endometrium. So myoma mapping is a very important part of fibroid evaluation. Then the pregnancy risk stratification is one of the reasons. If you are scanning a woman with fibroids in pregnancy, of course, you want to sometimes explain the underlying symptom. Well, these women may come with pain due to red degeneration, but you also want to the ultrasound report to be able to risk stratify the woman. We have come across in our web where the placenta overlies a very big fibroid, and these babies have had challenges of growth, fetal growth due to this poor placentation caused by this huge fibroid, which interferes with the blood, with the retroplacental blood supply. We also have fibroids that actually go on the lower part of the uterus and cause malpresentation or block the baby from coming out, and these women need to be sectioned because they have a blocking fibroid, which is causing what you call a myoma previa. So when you are scanning fibroids in pregnancy, you need to be clear with those points to say, when you are reporting fibroids, where are they? Are they interfering with the retroplacental surface? Are they bulging into the uterine cavity, or are they on the lower part? Are they on the cervix? Because if they're on the cervix, obviously they are going to interfere with cervical dilatation. Or they are the lower part and the presenting part cannot descend beyond the fibroid, so that people know what mode of delivery needs to be employed for this part of my audio.
Good evening, guys. Sorry for that, but we're trying to work on the.
So, is it okay for me to continue now?
Not yet. The volume is a little bit down.
My volume is down.
Yeah, could you use the first device? I can see your own, the Verenga Claudius Verenga.
Okay, let me use the other device. Sorry.
All right, thank you.
Sorry, guys.
Okay, I think it's better now.
Much better.
Let me remove the volume on this one. Okay, how is it? I think it should be okay.
It's perfect.
It should be okay now. So yes. If you're okay, if you guys are okay, I'm going to continue and say for fertility, not all fibroid locations will cause subfertility, but there are some fibroids that will cause fertility, subfertility, like submucosal fibroids. So it is important to be able to pinpoint the location of the fibroid, to know exactly where this fibroid is, so that the other person on the other side who interpret your scan will be able to explain to the patient what is going on. An ultrasound scan is a very important tool in the patient care pathway, so that it could provide some answers that will normally be very difficult to get without it. Then these are the common presentations of fibroids. I didn't list all of them, but Zimmerman, in his cohort of almost 21,000 women, mostly from Europe, America, and one Asian country, he looked at almost 21,000 women whom he compared, those with fibroids and those without fibroids, and he looked at the symptoms. And he noted that women with fibroids are more likely to have heavy menstrual bleeding, are more likely to have prolonged duration of menstrual cycles, and bleeding between periods, frequent periods, irregular periods, light menstrual, absent periods, infrequent and shortened duration of menses. So in other words, fibroids cause menstrual disorders. On top of that, women with fibroids will present with pain. The pain may vary from just chronic pelvic pain to dyspareunia. Dyspareunia means pain during sexual intercourse. And they may also have pressure symptoms on the surrounding organs. As you know that the pelvis is a compacted space, whereby if one organ overgrows, it's more likely to press on the others. It could press on the rectum behind, or press on the bladder in the front. So women could present with urinary symptoms, or could present with issues to do with defecation, depending on the size of the fibroids. So fibroids can cause a lot of a different kind of symptoms in different women. So you should always be aware of this kind of symptom that fibroids can cause. However, we should also be aware that the majority of women with fibroids are actually asymptomatic. More than half of women with fibroids are asymptomatic. As a result, the actual prevalence of fibroids, say how common are fibroids? Because whenever we discuss a condition, you want to know how common is this condition we are discussing. The actual prevalence is not known, but we know that it varies from between 5 to almost 40 to 50%. And also this prevalence changes with the woman's age. If we were to take women around the age of 45, Black women around the age of 45, and we scan them, we may find out that 50% of them have fibroids, and the majority of them are actually asymptomatic. But if we take young women who are around the age of 20, 21, probably 1 to 2% of them, or less than 5% of them, are going to have fibroids. So fibroids do vary, especially race. They are more common among Black women than they are amongst the Caucasians, and also vary with the woman's age. The older the woman gets, while still within the reproductive age group, by the way, the higher the chance of fibroids. And the fibroids will begin to sort of self-resolve post-menopause in most women. Sorry. Where am I? Which one? Okay. And these are the risk factors. You may wonder, how do fibroids come about? It is believed that there are some underlying genetic factors that could explain also the race issue, why they are more common in Black women. Age, I've already told you that the older a woman gets, while it's still within the reproductive cycle, the more the chance of them having fibroids. Women who have early menarche. Early menarche means starting the cycles very early. If the woman starts, they have cycles very early, they're more likely to have fibroids. Parous women, parity, just giving birth on its own, is slightly protective, so that fibroids are more common in nuns so that before people were aware that they can happen in even reproductive women, they used to be called tears of a disappointed womb. But we now know that even women who have had 5 children could potentially have fibroids. But if we compare with nuns, they are more common in nuns. I'm losing you again. Why? I can see I'm losing you from my other device. I'm sorry, guys. What this internet? It's Wi-Fi, the best Wi-Fi in our country, but I don't know why it's behaving this way today. Yeah, let me just reshare my slide. Sorry about this. Okay, so yeah, so we are back. And there are other factors like obesity, high blood pressure, caffeine, and alcohol. They all may contribute to the increased risk of fibroids. Why are we saying sharing this information? They are part of history evaluation. Then I'll come to this slide of terms and definitions. If you have not gone through this paper, it is important that you go through this paper so that you understand the consensus that this group came up with. It's a very important consensus when you are describing or writing your report after having scanned a woman with fibroids. So the Musa group, they agreed on certain terminology, which I'm going to describe as we go on with the presentation. But they agreed that we should use certain terminology and we should look at certain things whenever we are describing uterine masses. I think I also emphasized this when we were doing the endometriosis. The same information applies to the fibroids. Let's start with the evaluation of a normal uterus. Because for us to be able to localize the structures properly or the lesions properly, we need to be able to know normal uterine anatomy. So this is uterine cavity, and this is the endometrium. We also see this here in normal in a normal uterus. Normally, the endometrial cavity, it doesn't feel like a cavity unless there's an abnormality and there's fluid there. It's normally collapsed between the two endometrial walls. You can see there, which have increased echogenicity there. Then we have this inner myometrial wall. The inner myometrial wall is the one that is forming the endometrial-myometrial junction here. So this inner myometrial wall is very important for fertilization. It's very important for fertilization because this is the inner wall that reacts, and together the myometrium is the part of the myometrium that actually performs peristalsis movements that allow the movement of the fertilized egg towards the endometrium. As you are aware that I'm not sure if probably you might not be aware, but peristalsis happens bidirectional. It changes within the luteal phase and the proliferative phase, the direction in which the myometrium moves. During the proliferative phase, it is opposite towards the fundus, because normally the peristalsis movements, the contractions, they start at the cervix going towards the fundus. But during the luteal phase, where fertilization is probably expected to happen after ovulation, it happens opposite. It's a way of trying to pull the fertilized egg all the way from the fallopian tubes all the way to the endometrium. There are blood vessels that are responsible for vascularizing this area. And if a fibroid is infringing around this area, it has the possibility of interfering with fertilization. So it is important to know about this inner layer, inner myometrial layer, because it's very important for fertilization. The inner myometrial layer it may be very difficult sometimes to identify on ultrasound, But if you have a very good machine, you can imagine it as you can see here on my image here. Then of course we have the outer, the middle myometrium, the outer myometrium, and of course this subserosal layer. So fibroids can be located at any part of the uterus, from the cervix all the way to the fundus. So whenever we are looking at the fibroids, what is it that we should be checking for? Of course, first of all, we should be able to identify through its characteristics that this is a fibroid and distinguish it from other lesions that may mimic the fibroid. So we should be able to say this is a fibroid by identifying it through its characteristics, which we'll list just now. Then we should be able to measure the size, which we do in 3 orthogonal planes. You guys are experts in this. Then we should be able to count the number, the numerical count of the number to see how many fibroids there are. Sometimes it's extremely difficult. There are multiple, but an effort must be made to count the number of these fibroids. Then we should localize. When I'm saying localize, there's another slide coming out of this to say, what do we mean when you are saying localizing of the fibroids? Then, of course, you should be able to describe their appearance. How do they appear? Is there evidence of either calcification, degeneration, or there is evidence of red degeneration? And of course, the vascularization pattern should also be described. But we know that normally it's circumferential vascularization pattern we normally see in fibroids instead of the intralesional we see in adenomyomas. So if fertility, if you are investigating the women for fertility, because women may come to you because they are 45 years old and they've been having severe pain and they don't know why they are having this pain. But somebody may come to you for fertility investigation. They'll tell you, my doctor has referred me to you because I'm failing to conceive. Then in that case, if you find a fibroid, the relationship with the endometrium and this inner myometrial wall should be mentioned because it is of importance in infertility. The fibroid could be the reason why the woman is failing to conceive if it is interfering with these structures here. So it's very important to know the context. This is why history is important, and you cannot examine somebody without taking their history. If pregnancy, then the relationship of the fibroids with the placenta should be mentioned, as well as the uterine cavity, to say, is this fibroid indenting into the uterine cavity? Because if it is indenting into the uterine cavity, it may interfere with the lie of the baby, if it is big enough. If it is being overlaid with the placenta, if it is occupying the retroplacenta space, certainly it will interfere with the vascularization of the retroplacenta space, and this baby may suffer from late onset fetal growth restriction when the demand is increased. The same way with the uterine cavity and the cervix. We want to know its relationship with the cervix. Is it an obstructive myometrium? Is it causing what you call myoma previa or not? This fibroid. So this should be mentioned because it's very important. So when we are saying localizing, there is a classification that FIGO recommended. So FIGO has recommended that whenever you scan myometrium, this is how you should classify them, so that anyone who reads your report will know what you're talking about. So let's start with the ones which are submucosal. So for the submucosal, we have 3 classes under the submucosal. We have the 0, 1, and 2. Which one is the 0? The 0 is that pedangulated intracavitary. Sometimes it may even pop through the cervix. These pedangulated ones, they may pop through the cervix. The importance of doing this is that the approach to even surgical removal of the fibroid is different. Because for this one, we're not going to open the abdomen to try and cut through the uterus and remove it, but it's going to be removed through the cervix. So being able to localize an intracavitary fibroid is very important because it will modify the surgical approach. And if there is a woman who is failing to conceive, we'll know why she's failing to conceive. because the fibroid is interfering with the endometrium. So the class 1 under the submucosa, they make they indent less than 50% of themselves into the endometrial cavity. Then the class 2, the class 1 goes less than 50% into the myometrium, intramural here, while the class 2 goes more than 50% intramural, that is into the myometrium. So in other words, this one is bulging more into the submucosa than the class 2. Then we have the others. Under the others, we have a fibroid that conducts endometrium, and it is 100% intramural. It is important to be clear with this one, to say it is indeed conducting the endometrium. Remember what we said about fertility and the issues of fibroids and fertility. So the 3 will be conducting the endometrium. Then 4 is not in contact with the endometrium, is purely intramural. Then 5 is a fibroid which is more than 50% intramural, but it's a subserosal fibroid. That's number 5 here. Then number 6 is a subserosal fibroid which is less than 50% into the myometrium, the intramural portion. Then 7 is a pedunculated subserosal fibroid. We also call this one parasitic fibroid, because we are saying it's drawing its food and nutrients through a stalk from the uterus. Then we have these hybrid leiomyomas, the 2 to 5, these ones. This fibroid is impacting both the submucosa and the subserosal layer, with less than half of the diameter in the endometrial cavity and the peritoneal cavities respectively. That's the 2 to 5. So that's the classification of fibroids. Then in terms of the appearance, fibroids may vary as described in the same paper, this paper by Van der Bosch, that they may vary, these fibroids, in terms of how they appear. And I think we have all experienced this if we do scans. Sometimes we see a fibroid that is hypoechoic, like this one. But one mark of a fibroid, which should be able to distinguish it from adenomyosis, is that it's a wall-circumscribed lesion whose margins are clear because it has got this pseudocapsule around it. So it is a pseudocapsule around it, which is a very important structure for surgery because it allows the shelling out of the fibroid. However, it is in this pseudocapsule that the vasculature is sort of engulfing the fibroid. So they bleed during surgery, fibroids. So then we have an isoechoic fibroid. An isoechoic fibroid may be very difficult to identify because it looks just the same as myometrium. So it may be tricky to distinguish it from adenomyosis sometimes. But of course, we have to look for other features of adenomyosis, things like distorted endometrial myometrial junction, the issue of shadow speculations on the endometrium, or with adenoma, which comes with adenomyosis. Of course, we may also see this with calcified fibroids. Then we have hyperechoic fibroids, which are normally due to calcifications, as we can see there. Then we can have the mixed one. That means we have both calcified area and some anechoic areas within, and we can also have echogenic areas due to calcifications. When they are calcified like this, sometimes they may mimic adenomyosis, especially if the margins are not very clear. But if the margins are clear, then you can easily distinguish it from adenomyosis, because adenomyosis also has calcification and some shadow behind it. Then we could have red degeneration. Red degeneration is common in pregnancy, where the center liquefies due to necrosis, because the fibroid will enlarge and overgrow the blood supply. That's what we call cystic degeneration. We normally label it red degeneration. This is very common in pregnancy and is associated with severe pain. Women who go through pain, secondary fibroids in pregnancy, they really feel it. This is one of the reasons why whenever you see a fibroid in pregnancy, one of the counseling message to the woman is to let her know that this fibroid may give a pain, so that when she gets pain and she goes to a 24-hour, nobody would think that she has an appendicitis and to operate her for a normal appendix. This can happen because of the severity of the nature of the pain, especially in the hands of general surgeons, who may not be knowing that there is a fibroid there causing this kind of pain. So vascularization, the vascularization probably, you guys are familiar with the vascularization, but what is common with fibroid is that they give us a circumferential vascularization instead of the intralesional. This is very important when you are struggling to say, are you dealing with a fibroid, or are you dealing with an adenomyosis? Because adenomyosis will give you this intralesional vascularization. So this may help in distinguishing the two. So this vascularization, more so if the fibroids are seated around the endometrial myometrial junction, these vascularizations, of course, are going to interfere with the normal vascularization of the uterus and the endometrium. This is one of the role fibroids may affect fertility if they are abutting on the endometrium. Then the MRI versus ultrasound in fibroid evaluation. You may wonder and say, when is MRI better? Of course, MRI has been in fibroids and ultrasound can have been compared before by Dolem. And they showed that MRI is equal to ultrasound scan in terms of diagnosing that they are indeed fibroids. If you want to know, are they fibroids or not, both MRI and ultrasound scan, they perform the same. But MRI will become superior if the uterus is big or there are multiple fibroids. Remember, we were saying you have to count the number of fibroids, the myomas, but sometimes it's difficult with the ultrasound scan, especially if it is big, because there will be shadows behind the other big ones. You won't be seeing what is behind the shadows. So MRI will take care of that. So the MRI will perform better if the fibroids are many in terms of telling us the number of myomas, the actual size of the myomas. If we are scanning gynae patients, we have also all scanned those patients where the fibroid is out of range of the sector width. You put your ultrasound scan, you widen the sector width the best you can, and you can't measure how big that fibroid is. So MRI will take care of this. And also MRI will help us in terms of localization, giving us these classes. MRI performs better when it comes to the classification like this. So what are the indications? When should you consider or recommend and say, I think an MRI will evaluate better here? Of course, if the patient has got multiple fibroids and they want to undergo surgery, and if the surgery is for fertility preservation, not to remove the uterus. If you are going to remove the fibroid in the uterus, of course, there's no need to for somebody to undergo MRI just to do myoma mapping. There's no need to map them here. But if the woman wants what you call fertility preservation surgery, where they are saying, my doctor told me that I have to have my surgery removed so that I can undergo IVF, in that case, an MRI is very important, so that the surgeons will go in knowing the amount of work involved, whether they are going to breathe the endometrium, whether the fallopian tubes. That's another thing which I missed there. You also have to mention the relationship with the fibroids with the isthmic portion of the fallopian tubes. You want to know whether the fallopian tubes are squashed or are they indenting, or this surgery will involve cutting through those tubes or involve transecting through the endometrium. All this is very important. Then for large fibroid masses, where you cannot correctly define the extent of the fibroids, whether they are multiple, and you can't see where it is ending. In this case, an MRI will help. And of course, fertility evaluation, like I've just said, because we need the minute details of where the fibroid is seated. Then fibroids and subfertility. This question has been answered by many studies, including a systemic review like this one here. What is agreed is that fibroids that will interfere with fertility, especially for women who are undergoing IVF, are fibroids which are submucosal. The mechanism of action, these are some of them, that they will increase uterine contractility. I was telling you about the contractility of the uterus, that within the follicular phase, the contractions will be from the cervix all the way to the fundus, but post-ovulation, there is a reversal of those contractions. So sometimes the fibroids, through the release of prostaglandins, because when fibroids are inflamed due to some either red degeneration, some degeneration, or just local irritation, they may release prostaglandins that will increase the uterine contractility. And this uterine contractility will interfere with the sperm movement or the fertilized egg movement during conception. The deranged cytokine profiles will also interfere with fertility and abnormal vascularization. I think we've just stressed this point when we were doing fibroid vascularization, that since the fibroid is vascularized peripherally, it's going to interfere with the blood that supply the endometrial, myometrial junction area, which is very important for fertilization, because that's the area where the egg is embedded, right? Where the fetus will be embedded, right? So then chronic inflammation can also occur with fibroids, and this is one of the reasons why sometimes women may end up going to preterm birth, this chronic inflammation, but this also does interfere with fertility. So in terms of what exactly do fibroids affect? They do not affect much to a very big significance the clinical pregnancy rate, because as you can see, the P is 0.05 there, but they affect the implantation rate, and they affect the ongoing pregnancy and live birth rate versus live birth rate, and they affect spontaneous, they cause spontaneous abortion rate, preterm delivery, not much, but miscarriage, yes. So in terms of pregnancy, how do they affect the pregnancy? How they affect pregnancy is best summarized by Coutinho here, this diagram by Coutinho, to say in first trimester, like we were saying, that fibroids may actually cause uterine contraction due to ischemia, because sometimes they may overgrow the blood supply and cause ischemia, and these uterine contractions may cause the fibroid, the pregnancy to be miscarried. Besides them interfering with the implantation, they may also cause this, because it has been shown that fibroids actually grow so much in the first 7 weeks of from fertilization due to these hormones, the estrogen, the progesterone, the SCG, and the other growth factors. They cause the fibroid to grow so much. When the fibroid grows, because the vasculature is peripheral, the center will be undersupplied, leading to infarction. And that infarction, which is more of necrotic infarction, this will cause inflammation. And this will cause the release of prostaglandins, which will bring about contractions and a miscarriage. Then in terms of mid-gestation, what else can they do, fibroids? Like I said, that if it overlies the placenta, this may affect fetal growth. But if it is indenting into the endometrial, into the uterine cavity, this may cause malpresentation. This may cause transverse presentation, breech presentation, persistent oblique, and sometimes the presence of fibroid is thought to increase the risk of placenta previa, whereby the placenta will insert covering the internal os. In cases where it occupies this part of the uterus, then in that case it will cause obstructive previa, whereby the huge fibroid will obstruct the passage of the baby, and these women have to undergo surgical delivery, cesarean section. So through the inflammation, the red degeneration, and the release of prostaglandins, they may cause preterm birth as well, fibroids. We have had women who have lost babies, we had very virulent or very troublesome fibroids, which were undergoing red degeneration. They were always in severe pain and end up losing babies from this. So, yeah, so then after delivery, what happens is that normally the normal ischemic, the normal evolution of the uterus that occurs also affects the fibroids, so that the fibroids will undergo apoptosis as well, so that some fibroids may actually regress to small ones. Some may disappear after pregnancy. If you have scanned women who had fibroids before they were pregnant, and the next time you see them, the fibroids are gone, don't be surprised. This may happen due to the natural remodeling, which occurs to the uterus post-delivery, and also the cutting off of hormones, which occur post-delivery. However, fibroids, especially if they are huge and occupying the intramural space, they may interfere with uterine contraction. This will predispose to uterine atony, and which will lead to postpartum hemorrhage. So what do we do? Women with fibroids, huge fibroids, they are at risk of postpartum hemorrhage, and we manage them as such. So these women, we actually prevent PPA before they even bled. We make sure you infuse oxytocin and give them prostaglandins whenever they have huge fibroids in pregnancy. So this is the importance of really characterizing fibroids, their size, their location in pregnancy, so that the care team who go on to deliver, they know exactly what the risks of this pregnancy are. These are some of our images of fibroids in pregnancy. You can see this fibroid was just overlying the uterus, but it was not very big. Maximum diameter was 49 millimeters, overlying the placenta. This is the placenta there. So it was at the back of the retroplacenta space. You can see it. This fibroid is the same fibroid measured in the other plane. This pregnancy was okay. This baby didn't suffer from this is another subserosa fibroid, just overlaid slightly by the placenta margin there. Not much effect. Normally subserosa fibroids, the only thing that they may cause is pain in pregnancy, but normally they don't affect the overall outcome of the pregnancy, to be honest, these subserosa fibroids. Then in terms of our differential, remember the condition we discussed the last time, we discussed adenomyosis. Adenomyosis, if it is like this, it is easy, because you are not seeing much of a circumscribed lesion, except that you are seeing that this area looks more hypoechoic, not all circumscribed, and appears thicker than the anterior wall. And this is the endometrium there, which is thick in this case. This was a case of adenomyosis. Sometimes it may appear like this and deceive you and say, what are you looking at? If you look carefully, you can see that it's not well circumscribed here. And what you are seeing are more like shadows, and the endometrium echo is obliterated. So these findings are more in favor of adenomyosis than, and also the uterus is globular. Remember when you did endometrium, it will appear globular in shape. So this favors more of an adenomyosis than a fibroid. It is very important to distinguish the two. Because if you tell a doctor that the doctor has referred the patient to that there is a fibroid instead of adenomyosis, the doctor is going to go in there will take the patient to theater to look for a fibroid and they will not find it, because adenomyosis cannot be resected out unless if it is an adenomyoma, which will show some, which will have some margins, but it's extremely difficult in the blades. This is because adenomyosis nowadays, you don't have to do surgical. You just give somebody Mirena coil, which is put inside here, and they get better in terms of the symptoms. So adenomyosis, unless if the woman is finished giving birth and they just want the uterus chopped, then that's fine. But for a woman of reproductive age group, it is important to distinguish the two entities, because they could be taken to theater for an unnecessary operation, which would be a false operation actually, because they will not find the fibroid. All they will see is a hyperemic uterus, which looks well vascularized and global and big. So this is another case of adenomyosis. In this case, if you look carefully here, you can see that there's something that looks like a fibroid, but because there are other overwhelming features of adenomyosis, if you remember this sort of endometrium from the endometrial talk, the invagination of the endometrium tissue into the myometrium here, this is overwhelmingly in favor of more of an adenomyoma than a fibroid. So that's the differential which we have to be watch out for. So my conclusion is that fibroids are very common amongst our people. They are more common in Black women, which is likely more, which is predominantly present in Africa here. And it is important that we all make an effort to be able to evaluate the fibroids properly, and we be able to classify them and to localize the fibroids in terms of where they are, so that when we report, the report will make a meaningful contribution to the care pathway of the patient. And my overall recommendation is that we should adopt transvaginal scan. This one, we all have to preach this message, because honestly, why Africa? I've been to countries where they do not even think that there are people somewhere in this world who examine non-vigo interactor women with the transabdominal approach alone. There are countries like that. They're actually surprised that there are people like us who are still doing transabdominal alone. So you can imagine where we are, and it is up to us guys to to move ourselves away from medieval practice to catch up with others, and so that we can compare our results to those of others. Because as it is, the transabdominal approach, nobody will listen to your story if you told them that you evaluated a pelvic pain woman transabdominal and you stopped there. Nobody will listen to your story, because that story is a lot of errors. Then let us use same nomenclature in describing pelvic pathology. So let's use the nomenclature as recommended by the Musa group. That paper is available for free download on the internet. So please download the Musa group, read it, familiarize yourself with the terminology, so that when you are writing your report, you use the right terminology. Of course, training is vital. One of the things with the ultrasound, it is acknowledged throughout the world, even in high-income countries, that there is not enough ultrasound scan performers or skilled personnel as a result. But however, there's very little of training which is happening, or the training schools are training so few numbers, so that we'll never be able to address the gap we have in the next 2 decades or 3 decades. But I want to advocate that ultrasound should be trained. Anyone who is competent should be seen to be training others, so that they can become competent, so that it becomes widely available, because ultrasound is like the modern day stethoscope. To say anyone who is practicing in the medical field should have some competence in ultrasound, some level of competence. The level of competence will vary, of course, from specialists, but some competence should be established. Thank you so much. I think that's the end of my presentation. Yeah.
Thank you